for. Hope this finds everyone doing well. I know that a lot of people are out doing weekend intensives this weekend. I hope those of you are enjoying them. Those are coming to an end now. Like I had said before, I'm in Nebraska this weekend. Just wrapped up a course I was doing on low back pain, of all things. So I apologize for getting this out late. Usually I get these out on Saturday. But here it is now. So here we go. Let's talk about some adhesive capsulitis and some shoulder instability. So just a couple of things that I want to bring up. I thought everybody did. We had a pretty good week this week. There was some really good dialogue on some different topics. I thought everybody did a really solid job on their cats. Most people were able to come to the appropriate conclusions. A few people struggled with some of the statistics, and in most cases the statistics weren't available, and I think it goes to show us that in those cats we aren't able to fully get a full appreciation of the literature, because oftentimes the actual documentation is not being presented, and so then we don't know. And I think that speaks to sometimes the frustration in the literature when you do systematic reviews and such. And so, but as a general rule, everybody was able to come to the similar conclusions. And everybody had kind of their own take on things, but I thought everybody did a solid job. Now, in regards to adhesive capsulitis, I just want to speak to that presentation that Bob Boyle's, the staging, being able to stage your frozen shoulder, I think really is appropriate, is important rather, appropriate probably as well. And then educating the patient about what's happening. Why is it that this thing is? Why am I losing motion? That's usually when you see people, right, when they're starting that freezing phase and they're losing motion, and they come in and they say my shoulder range of motion is not really great. Sometimes they have a lot of pain, sometimes they don't. And then you start working with them, and they start to appreciate truly how limited they are. Know the patient population that's greatest at risk. I think this is a really good thing. Female diabetic, 40 to 65. That's the classic shoulder adhesive capsulitis patient, and being able to appreciate the level of irritability, know when it is appropriate to push hard and know when it's not, right, depending on the stage. If they're in the frozen stage, in a lot of cases you can really pound on them. They can push hard on themselves as well. He mentioned that the oral steroids have demonstrated significant short-term benefit. Does not last longer than 6 weeks, however. Let's go to this next slide, because we'll swing into the clinical practice guidelines of the stiff shoulder. So as we roll in with the corticosteroid for short-term 4 to 6 relief and A rating, I was kind of surprised at how many people were that information was new to them. I guess I use that. I don't say I'm quick to do it, but I would say that 2 to 3 visits, and if you're not better, I am certainly pushing for that option. And better meaning you're able to engage in your exercise program, you're tolerating treatment well in the clinic, and kind of understanding. I had a woman who did not want an injection. She was just opposed to needles. And so we really struggled because she had a lot of irritability, and trying to get at it from different directions was tough. But appreciate the strength of which that steroid injection brings. Outcome measures, obviously, that helps track progress, probably helps you stage it too, or helps you understand when they're leaving a certain stage, right, when it starts to get better. Usually my take on that whole thing is that I'll tell them, I'm going to see you probably 2 times a week for a few weeks, and then we'll go once a week for a couple of weeks, and then we'll go out every other week. And I'll tell them, I'll say, we're not going to get all of your motion back. If you were a baseball pitcher, you're not going to be able to pitch when this whole thing is said and done, but you'll be functional, and you'll be able to sleep at night. You'll be able to get dressed, and you'll be able to sleep without waking up because of pain. And those are both things that they can appreciate. The stretching has B rating modalities. Joint mobilization, translational manipulation, that's only got a C rating. I think the translational manipulation stuff, a lot of people, we talked about this. I certainly brought it up. I brought up both joint mobilizations, looking at the article that talked about high grade versus low grade, and that they both seem to do about the same. So if somebody is really irritable, but you're able to get 1-2 grade mobilizations, that could be just as effective. And then the translational manipulations, there's some good discussions about, what could PTs be doing? How could they be doing more of this? And it would be my take, and granted, I'm a bit of a hypocrite because I don't see a ton of this, and so I don't seek it out, but I personally would make friends with an anesthesiologist, and I'd talk to them about having them sedate my patient, and then doing the translation. I wouldn't even include the orthopedist, to be quite honest, as long as primary care was aware of the situation, and we'd have to, again, it'd have to be passed through the rehab management, but in reality we should be able to do this. And these gross manipulations that they're doing, they don't do any good, and then they just make people sore, and they don't give them any more emotion. Enough on that. Rolling into this trigger point dry needling article by Derek Cluley. I think the one thing I forgot the L there. Sorry about that. I think the one thing that's important is not so much even the dry needling, because I'm not even convinced, as I'm certified in dry needling, so I dry needle, and I would dry needle a frozen shoulder person if they were appropriate. But I think what's really important to understand is the clinical decision making that went into this. He was really very, he didn't start with dry needling. Dry needling isn't something you do every time for every patient. He was very judicious about it. He went after very specific things. Is it an opportunity for quicker change? It could be, depending on the right patient, right? We still don't know. This is a case study. Shoot, all we know is that this person could have absolutely loved dry needling and thought it was the greatest thing since sliced bread. And if you had 100 people, maybe they all don't really love dry needling, and so you don't get the same change. Take it as an opportunity to understand the clinical decision making, but then also appreciate the fact that it was one case study. Seems to be good for pain modulation. MCID at 2 visits once introduced, and that's, I think, the greatest, in my mind, the greatest issue here is that how quickly it changed right after 2 visits. Thoughts. Continue to consider regional interdependence for improvements. Whether it's a shoulder instability or it's an adhesive capsulitis, appreciate those effects. High grade, low grade, again, similar effects. I talked about translational manipulation, and then with the instability, whether it's FES and a CVA, or somebody who has either a hypermobile from a trauma or congenital hypermobility, understand that stability and motor control and regaining strength is always a good thing. And I'll go back to weight bearing for those patients too, because I really feel like that's a big deal. Get them in weight bearing, getting them this kind of gross firing pattern is a strong thing. All right, sorry to ramble. Review the syllabus. Make sure you're continuing to aware of what's happening, because the game changes a little bit. I'll be sending out, included in this video, again for the 3rd time, the new groups. You'll have new groups that you'll start on Monday. I'm gonna be working on mid-quarter grades tonight and Monday, hopefully on my flight back, and be getting them out to you guys, hopefully no later than Wednesday. Look at your group project information. I've told the people that are first in the group that they're just in charge of getting everybody going, not in charge of doing any more work, but just kind of getting the wheels turning, so to speak. So don't take advantage of them. And then knowing that we're going into lateral elbow pain, review of the elbow, the wrist, and manual therapy associated with that. Hope you all are doing well. I've enjoyed this week and all of your insights. I look forward to further discussion about the elbow. It's a great place with a lot of interesting opportunities. So I look forward to the discussion. I look forward to giving you all feedback about your progress so far this week. So not only will you get your grades for midterm, but I'll be providing kind of a brief update on what you could be doing better, if anything at all, to help you get more out of this course. And if you feel like if you have any questions for me, again, don't hesitate to reach out. Take good care. Bye-bye.